I'd now like to welcome representatives from the Department of Health, Disability and Ageing to this public hearing of the Standing Committee on Health, Aged Care and Disability. I'd like my committee members just to identify themselves, starting from Ms Stanley.
Anne Stanley, I'm a federal member for Werriwa in South West Sydney.
Alistair Baird, member for Gorton, Melbourne's Western Suburbs.
Ailey France, member for Dixon in Queensland.
Sophie Scomps, member for Mackellar, Northern Beaches of Sydney.
Monique Ryan, member for Kooyong in eastern Melbourne.
Mike Freelander, member for Macarthur in South West Sydney.
Sam Beryl, member for Nichols in Northern Victoria.
Gordon Reid, member for Robertson, Central Coast, New South Wales.
Henry Pike, the member for Bowman on Brisbane's Bayside.
Good. I'd like to acknowledge we're meeting on Aboriginal land and pay my respects to any Aboriginal people here today. And once again, I'd like to thank you for coming and presenting to us. We are completing our inquiry into the effects of alcohol and other drugs on the Australian community and how best to manage them. And if you could identify yourselves, and would anyone like to make an opening statement?
Good morning. Thank you for inviting us. My name is Trish Clancy. I'm the First Assistant Secretary, Population Health at the Department of Health, Disability and Ageing. I'll ask my colleagues to identify themselves, and then I do have an opening statement.
Good morning. My name is Ben Medalli. I'm the Assistant Secretary of the Alcohol, Other Drugs and Food Branch in the Department of Health, Disability and Ageing.
Good morning, everybody. My name's Avi Rivera. I'm the Assistant Secretary for the Office of Drug Control, also within the Department of Health, Disability and Ageing.
Good morning, everybody. My apologies for being a few seconds late. Professor Robin Langham. I'm the Chief Medical Advisor of the Therapeutic Goods Administration in the Department of Health, Disability and Ageing.
Opening statement. Thank you for the opportunity to do this. So the Department of Health, Disability and Ageing thank the committee for the opportunity to appear before the inquiry and to provide an opening statement. I'd like to begin by acknowledging the Ngunnawal people as traditional custodians in the lands on which you're meeting today. I recognise other people or families with connections to the lands of the ACT and the region and wish to acknowledge and respect their continuing culture and contribution they make to the life of the city and the region. I'd also like to acknowledge other First Nation people who may be here today. The Department has drawn valuable insights from the March 2025 issues paper and evidence submitted to this inquiry, which together highlight an opportunity to implement practical solutions and move beyond the current AOD landscape. We're seeing continuing patterns of harm across illicit drug use and alcohol consumption. Notably, illicit drug use increased by over 12%, from 3.4 million people in 2019 to 3.9 million people in 2023. In 2023, Australia lost almost double the number of people every month to preventable drug overdoses than died on our roads. Highly potent synthetic substances such as nitazines, which are up to 500 times more potent than heroin, are emerging in Australia. The potential for nitazine-related overdoses is underpinned by the fact that drugs such as ketamine, MDMA and cocaine are increasingly adulterated with these nitazines. Around 1 in 3 people aged 14 and over consumed alcohol at risky levels in 2022-23, and it contributed to 4.1% of the total burden of disease in Australia in 2024. At the same time, less than half of Australians who had benefit from AOD treatment accessed it. This means about 500,000 people missed out on receiving help in 2023. Since we last appeared before the committee, 2 developments have occurred. The government in the 2025-26 MyEFO announced the consolidation of the drug and alcohol programs, terminating and ongoing funding into a single ongoing program, providing greater funding certainty and stability for the AOD sector. This will support longer-term planning and service continuity, while reforms to strengthen program design and outcomes are progressed. From 2026-27, this includes an investment of $729 million over 3 years, followed by ongoing funding of $244.2 million per year from 2029-30. The Department will consult with the sector on the redesign of the grant agreement commencing on July 1st, 2027. The redesign will not change the fundamental objectives or service types under the drug and alcohol program, but will include updates to the program logic and KPIs, etc. Consultation on the DAP reforms will be undertaken in 3 stages, with the first closing tomorrow, Friday the 13th March. Further information is available on the department's consultation hub. The second change that has happened since we appeared before you previously is the establishment of a national AOD strategy working group. Establishment of the working group was supported by all members of the Health Chief Executive Forum and the Police Ministers' Council senior officials meeting in February this year. The working group's primary focus is the national drug strategy and any future iterations. The working group will enable better coordination and collaboration among participating health and law enforcement agencies on initiatives relating to alcohol and other drugs, with the aim of maximising the impacts of new investment, consistent and complementary public-facing messaging, and sharing data to inform responses to alcohol and other drugs and related harms. We thank you for your time and welcome any questions you have.
Thank you. We might start with Ms. Stanton.
Thank you very much for coming. I don't have any at the moment.
Thank you. I have a question around, I'm really interested in the impact of alcohol and other drugs on young people. I represent one of the youngest electorates in the country. I'm really interested in pill testing, and in Victoria we've seen a trial at some festivals around that sort of community-based intervention. I was seeking your perspective on initiatives like pill testing and if there's an appetite to roll them out across the country.
So I think that I will hand over to my colleague for some more details, but I might start by saying that these are state and territory responsibilities essentially. So rolling it out would be a state and territory decision. We do see it, I think it's in 3 states and territories in either a test or live phase at the moment.
Yeah, Ms Clancy is correct. So it is a state and territory responsibility, and they fall under the umbrella of what you describe as harm reduction measures. So we know that in the ACT we've got CanTest as one of those sites delivering pill testing. In the New South Wales there's a trial underway at the moment which is looking to bring pill testing to 12 music festivals across the year. And in Victoria, as you mentioned, Queensland did have pill testing, but it's since introduced legislation. One, it stopped funding state delivered, and then it introduced legislation to prevent any private providers from providing that kind of service. In terms of the evidence around it, I think the evidence is still being gathered around its efficacy, but the early signs are promising. And so I think when you look at the results that are coming out of CanTest, they show that there's a significant increasing numbers of people who are getting their drugs tested prior to using them. And then amongst those people, there are increasing numbers of people who are then disposing of their drugs after they get the results of that test. So in terms of being effective in reducing potential harms, I think we've got enough evidence to suggest that it's something that could be pursued by states if it's consistent with their policy objectives.
That's great, thank you. Are there any other sort of community-based prevention initiatives that you're looking at a federal level that you could talk to us about?
Happy to go. So I think, again, given that these are largely state and territory responsibilities, I think there's a question for what value the Commonwealth can add. And I think potentially there's a role that the Commonwealth can play, which is about bringing jurisdictions together to share their best practice, because it is an uneven playing field in terms of where each jurisdiction's at, noting that there are a variety of different harm reduction measures. So, some of that would include needle and syringe programs. We don't see them in every jurisdiction. Some of it relates to pill testing as a mechanism for early warning, and then the next step in that process is prompt response, and then you could argue that there's a further step in that process depending on what's coming up in both of those steps around overdose response. I think there's potentially a role for the Commonwealth to play to look at how you both bring those elements together or advocate for the sharing of best practice, and then looking at how do they all come together as potentially a national system. And at the moment we don't have that. It's all jurisdictionally specific.
We do fund a local drug action teams program across the country, and these are very small scale, very localised pieces of work supporting communities to address the needs as they see them. So I visited one of these that focused very much on migrant communities and recent migrant communities. So they worked in language, and they had very targeted messaging not just for say parents who'd migrated, but also for the children of migrants who've grown up in Australia but have grown up with kind of parents with maybe a set of values that came from their country, and now the younger person lives in a slightly different environment. So really very niche targeting of what they do.
I'll probably just add to that. They move beyond the spectrum of just harm reduction. They move into the prevention phase. So we fund initiatives that go right from that prevention to early intervention to treatment and rehabilitation. So there's quite a spectrum of activities we fund, and then the states have those harm reduction measures that we kind of almost sit around either end of those, as well as they also fund treatment and rehabilitation as well.
That's great, thank you. No further questions. Thanks, Chair.
Or we might go to Monique next.
Thank you. I'd like to ask you about nitocens, because they are a source of significant concern for people who've heard about overdoses and sometimes group overdoses associated with them. What steps has the Australian government undertaken to ensure that adequate doses of naloxone are available to those people who might need to access them emergently?
So we have the take-home naloxone program, which essentially enables people to access those substances in a much more affordable way than they ever were able to. So, and we've seen increasing uptake of that program. So it is our primary mechanism. We're aware that jurisdictions also have different mechanisms in place to enable frontline services to carry naloxone. So in WA, for instance, police can carry naloxone, so they're able to administer on a much more opportune basis potentially, other than relying simply on people who are using drugs to carry something like that. So we do have a program in place that enables access to naloxone, but we're also looking at how we can advocate for more sites of potential delivery for that.
What are the current means by which you advertise the availability of the service?
I don't know that I can speak exactly to how we advertise, but happy to take that on notice. I know certainly amongst people who use substances or opioids in particular and know that they're at risk of overdose, access is through pharmacies, and that's one of those primary interfaces in which people who know that they're engaging with others at risk can ensure that that's part of the engagement they have, so they know that that's available and they encourage the uptake of it.
Can I just ask, do you need a script for it, or you get it from the pharmacist?
You do not need a script.
Don't need a script.
And you get a single dose?
Yes.
I think it might be, yes. And there are different...
Sometimes better. So,
no, I'll leave it at that.
no. Okay. Thank you.
Ali?
I'm interested in the percentage of funding that goes towards the law enforcement treatment and harm reduction. 64% goes to law enforcement, 27% to treatment, and 1.6% to harm reduction. Can you just give us a bit more detail about that? And is that federal law enforcement? Are you talking about state and territory law enforcement? Because it seems a bit topsy-turvy in that we should be spending more on treatment and harm reduction, and of course law enforcement's important, but can you just give us a bit more detail on how that's allocated and what it goes towards?
Thank you for the question. Can I ask the source of your stats, just so I'm making sure
I think it's in... Well, it's provided to us. One of the...
I can talk to
I'll
it.
have to ask the committee, actually, the Secretariat. Yeah, is that all right?
I can talk to it in general without referring to those specific stats. They are directionally what I'm aware of.
Yeah.
But I couldn't say, yes, it's 64 and so on.
Yeah, that's okay.
Yeah.
I'm just like, whether it's 60 or 30 and whatever, Yeah.
So there are three pillars to the National Drug Strategy, which are about... sorry, you're going to have to tell me the pillars because they've just escaped my mind.
Harm reduction, demand reduction and supply reduction.
And the funding mechanisms are different across each of them, because we're, particularly the supply reduction is more of a law enforcement side. It is going through the law enforcement budgets. We are going through the kind of health budget. So they're different measures. It isn't that someone has a bucket that they then split across them. It is not only, Commonwealth, you have this, but you also have at a state and territory level kind of police/justice and health side of things, which is one of the reasons why the new working group has been set up, to make sure we're having the conversations across all these parties in all the jurisdictions. I don't tend to dwell on what percentage goes here or there. I tend to more think that the value is in focusing on what are we each doing and how is that contributing to kind of safety and harm reduction in general.
And I'll probably just add that when you look at how those funds are expended, we're talking about very different categories of location. So when you look at, say, harm reduction measures or any of the programs that we fund, they're very site-specific for the most part. Putting aside for a moment those sorts of projects that are national in their focus and have probably a more whole-of-population prevention focus. When you look at law enforcement, a lot of those costs are being applied at a far greater scale, and they're sunk costs. So they're not just there specifically around looking to reduce supply. The efforts around supply reduction will also be applied to any other substances or any other materials that might be illegal. And so it's a bit like comparing apples with oranges.
Customs, border force.
That's right.
Yeah. And local policing, would you say too?
That's right.
So that would be the just generic, yeah. I think it's interesting though to look at it from that holistic perspective, that the treatment part of it, well, I think we see in our communities seems to be, lower than we would like, I think. Yeah.
Thanks, Sally. Sam.
Thank you very much. First question is the alcohol and other drugs branch. Are we seeing a trend in what drugs younger groups of people are using in terms of alcohol or other types of drugs? And we have heard some evidence that is the case. I'd just like you to expand on that. And if so, is the way that the department approaches treatment and other issues and campaigns having to adjust to that?
So we are seeing changes, and it's a relatively, it's not a straightforward picture. So you can cut it up by what changes do we see in urban sites versus regional sites, what do we see by different age cohort, and what changes do we see by different sex cohort as well. So if you were to look at alcohol on the whole, alcohol use is declining for pretty much every age cohort and every sex cohort, but not completely the case. So young women in particular are sort of bucking the trend in terms of alcohol use, whilst everybody else is largely going down. Young women's use of alcohol is...
What's bucking the trend, sorry?
Young women's use of alcohol is increasing, whereas nearly everybody else is going down. I think perhaps older women may also be going up as well. But for males, it's almost consistently declining in terms of use. Men still use alcohol more than women, but the gap is closing considerably. When you look at, say, capital cities or urban centres in terms of use, we're seeing substances like tobacco decreasing, oxycodone decreasing, fentanyl, although it's not highly used, is still decreasing, and ketamine is decreasing. But methamphetamine, cocaine, MDMA, MDA, heroin and cannabis are all increasing. If you were to go to regional sites though, alcohol is decreasing, MDMA is decreasing, cannabis is decreasing, ketamine is decreasing, but methamphetamine, cocaine, heroin, oxycodone and fentanyl are increasing. Now, noting that the volumes of each of those substances are not the same and the rates at which they're increasing or decreasing varies across all of them.
And so the second question, which was, how are the strategies evolving to address those trends? But before I go on to that, can I just ask you a follow-up on the tobacco use decreasing and ask, is that based on how much legal tobacco is sold, or is that based on what we think is happening in relation to illegal tobacco?
That's based on our data on consumption of tobacco. We don't ask people where you got your tobacco when we ask questions about consumption.
So you survey them to say, you base that data on surveys of people's use. Okay, thank you.
Our highest, there's a little proviso around this. Our highest quality data is the National Drug Household Survey, the National Drug Strategy Household Survey. That's done once every 3 years. So our last set of data is 22-23. It was redone last year. We will get those results this year. We have a slightly lower quality data set that we use in the middle years, which they're showing the same trend. We've had a long-term decrease in tobacco consumption, as you may be aware, but those are very much consumption. It's asking, do you smoke daily, etc.
And the other question was about the department's response to the changing trends.
A lot of people who seek treatment have polyuse, so they will consume alcohol and another drug or more than one drug. So treatment providers are on the whole very used to dealing with kind of I do alcohol and alcohol is going down, so my business is going down. That doesn't exist in the treatment sector. They tend to deal with multiple use and evolve their practice depending on essentially the customer base coming through the door. With the drug and alcohol program refresh that's underway at the moment, we will be looking, of course, to make sure that the set of providers from 2027 onwards are well set up to deal with the drugs of the moment, but also kind of any future, have the flexibility to adjust as the times are, as the drugs of choice are changing.
Thank you.
Good.
Yeah. Hello. Thank you for coming today. My questions are, and some of this is going to be state-based, I understand that, are relating to emergency department presentations with alcohol and other drugs. The first one is, do you have any sort of numbers or evidence to provide as to the impact of alcohol and other drugs patients presenting to emergency and that contributing to either ED overcrowding or logjam, like bed block? And also then a follow-up question to that will be, does the Commonwealth Department assess bed occupancy and sort of resource burden of those patients who then go on to be admitted into hospitals?
I can answer the latter question first.
Yep.
No.
Okay.
It's not a data set we look at. Okay. In terms of ED data...
So again, we don't have that data, we don't collect that data, and happy to kind of take it on notice to provide you with more precise detail, because we could probably obtain that from our jurisdictional partners. Mm-hmm. I know anecdotally, if I've heard that if you were to look at emergency presentations 10 years ago, the bulk of those presentations would have been for where they involved alcohol or other drugs. They would have involved opioids as the primary source for that presentation. If you were to look today, and so it would have been, around about 80 to 90% of presentations would have been attributable to opioids. Today, it would be methamphetamine that's replaced that, and that's largely as a result of the effectiveness of our treatments. We've got effective pharmacotherapies, as well as things like take-home naloxone programs that effectively prevent somebody from having to present at a hospital to deal with their overdose. But methamphetamine remains the probably source of primary concern.
And then in your, adjacent question, and then in your collection of data looking at people's use of the different types of drugs, do you also collect data on how those drugs are administered, so smoking versus intravenous use versus sublingual use? Do you look at that? Do you collect that data as well?
I think
Like
that
how
is.
people take it?
I think that is collected through one of a number of surveys that the AHW administers, but I don't know whether that applies to all substances, because I think some substances, the primary method of consumption is very narrow.
Yeah. Okay. Good. Thank you. Thanks, Chair.
Good. And thanks. Look, I've got a number of questions slightly off the subjects we've been talking about this morning. Perhaps first to Professor Langham. There's been a bit of talk about the use of the new GLP-1 receptor agonists in addiction. Has any companies approached the TGA around those sort of applications or not?
Thank you for the question. At the moment, no. We've not had any dossiers submitted to the TGA for registration of management of addiction of those products yet.
Have you heard any information around that?
I probably hear as much as what you read in the general press.
Mm-hmm.
As far as I know, there's not a lot of larger clinical trial data that's available, but certainly with these products, there are a number of different new and exciting, interesting, novel avenues that they could be used in. But as to your question, we've not had any extension of indications for the management of addiction, no.
Right. Would any of the other members like to comment?
I think that would go through TGA. Yeah. So we would see it after Robin and Co would.
Okay. All right. Then is... Sorry, okay.
That's all right. I haven't yet asked a question, but I'll wait till you're finished.
Okay, good. Is there a role for a national system that looks at things like wastewater screening to see which, with more granular data on which drugs are being used around the country?
Currently, the Australian Criminal Intelligence Commission has a wastewater monitoring program. They produce reports, I think, at least annually, if not more than that. But again, happy to clarify. So they're already collecting that kind of data. If it was a question around whether there's a need for more wastewater monitoring, that would be a decision for government.
Yeah. And they feed that information to...
That information is publicly available.
Right, okay. We've heard also from the College of GPs around management of addiction and increasing the number of more prolonged consultations and also having availability, for example, in general practice to pill testing. Has there been any thoughts around that with a national program?
That is not something that's come across our desks. Certainly, so requests for changes to MBS numbers would go through our colleagues in MBD. We haven't heard about one, and they would have come to us if there was one being considered around pill testing, I imagine.
Right. Is that on the radar, though?
I think with the issue of expanding access to related services to GPs is a live issue, and one of the issues that impacts that, and this is not specifically in relation to pill testing, but other supports, be it opioid dependence, treatment and therapy, things like that. Stigma is an issue that is preventing uptake, so some GPs don't want to have clients that present with those sorts of issues, which we know the evidence tells us that the more access that people who use these substances can have access to care, the more likely we are to see better outcomes. And so there is a piece of work there that would benefit users greatly if we can have a positive impact on reducing the levels of stigma that currently exist.
Yeah. The reason I ask this is there is obviously a lot of pressure on governments to provide inpatient management programs, but they're very expensive, obviously, and there is some comment from some people that at-home management works better, enables people to get on with family management and other things. Has the department looked at other sorts of management programs that don't involve inpatient?
Certainly, as part of the drug and alcohol program refresh, we would be open to providers bidding for funding who had an evidence-based model that they used, for treatment at home as opposed to in residential. Yeah. There's nothing that we say you must be residential. As you'll be aware, the Australian, the more popular option in Australia tends to be residential.
Yeah.
That is not the case in all jurisdictions, not outside of Australia.
Have you looked at other programs? Or?
Well, in terms of the drug and alcohol program, we already have some activities that are delivering non-residential rehabilitation and care. So, as I said at the start, the full spectrum of activities, apart from those more specific harm reduction measures, are supported through the drug and alcohol program.
Yeah. And what jurisdictions do it well, do you think, in terms of non-residential?
I don't think we could talk about it at the jurisdictional level. It's more on a provider-by-provider basis.
Right.
And in terms of international, we haven't done the kind of comparative study that would give us the evidence of going, we should be, it's the X country model that's perfect. Mm-hmm. And often things are perfect for a scenario. They fit in a context.
Yeah. Okay. We did get a bit of evidence in the previous Parliament from the Federal Police about some of the new drugs that are being used, and nitazines did come up. How concerned are you about the increasing availability of nitazines?
I think we're concerned across the board with changes in harm and potential for harm. I think the adulteration of other drugs by nitazines is a particular concern. Yeah. So someone who thinks they're taking a substance that they've taken before, that they felt they could manage, and suddenly it's adulterated with something far more dangerous. I think that is of huge concern. And we're very mindful of kind of watching what's happening. And we see that there are other jurisdictions that have internationally have a larger issue than we do. And kind of mindful that those risks, extend to the market here.
As you might be aware, Chair, the Commission on Narcotic Drugs is currently holding its 69th session in Vienna at the moment, and on Monday all member states delivered their national statements. I think it was fair to say that the vast majority of them highlighted nitazines and emerging substances of concern as a key feature in their statements. So I think internationally we're seeing a growing number of substances emerging. I think the UNODC, the UN Office on Drugs and Crime, is currently monitoring about 1,400 substances. Now, they're not all nitazines, that's a variety of different substances, but the extent to which these sorts of substances can now be produced in relatively high volume and with levels of potency that far exceed things like heroin, which we would have once seen as, particularly potent, means that their trafficability presents a real challenge. So the volume and quantity that you would have had to have trafficked to generate some sort of commercial return is much smaller, which makes it also much harder to detect for law enforcement agencies as well. So all those features, both potency, ease of detection, the ever-changing chemical structure of these substances, and I don't know whether ODC wanted to comment on that at all, but I think those things together present concerns, noting at the moment we don't have the same volumes, but as other parts of the world do, but I think other parts of the world present sentinel cases for us in some senses.
Yeah. Can I just ask, again, slightly off topic, does nitazine overdose respond to naloxone, or...?
It does.
It does, but do you need to keep giving bigger doses, or...?
So I'm not 100% 100% certain of what the evidence says. I understood previously that your window of opportunity to apply naloxone and the dosage that you needed to apply was both smaller and larger, respectively speaking. But I've been advised that that's not the case. But better for us to take that on notice and come back with
that would be
confirming
great.
advice.
Thank you. Sure. Sophie.
Thank you. Thank you. I was just going to just quickly go back to the discussion about tobacco use, and you mentioned that the rates have been declining over some time. Was that declining as well for young people specifically?
Yes. So tobacco use has gone down from 20-something% in the early 2000s, like 2002, to about 10.6% for daily use. And the latest high quality data, which is 22-23.
Okay.
And that has gone down for all cohorts and all age groups.
Yeah.
Obviously, with the market at the moment, there is risk that you will see uptake, particularly in younger cohorts, because it tends to be if you don't smoke by 25, you never smoke. So you kind of, it's the 15 to 25 window is where people start smoking. But the data set we have at the moment, we will see obviously when we get the high quality data this year, the trends from last year.
There's been a suggestion that with the increased rates of vaping, that was translating into an increased uptake in tobacco use. I guess, has there been any interim sort of research looking at that, or we will wait for that research to come out?
We know that it is a risk. We have always been concerned that vaping is a kind of gateway into tobacco use, and prior to the reforms to vaping a number of years ago, we saw youth uptake of vaping. We don't have the data to back it up yet. We are in terms of our campaigns, etc., we are working on the assumption that youth are always a risk and that we should be heavily focused on youth.
Okay, thank you. And one of the other things I was interested in is, has the department moved away from reporting on population level health and wellbeing outcomes, such as the reductions in risky drinking and illicit drug use? Is that the case, or
not that I'm aware of? No.
No.
Good to hear. And then also just was interested in, are there national frameworks that the department uses to assess whether policies and programs are actually reducing harm and improving health outcomes?
So we have, we did an evaluation of the drug and alcohol program this time last year, and that showed that the drug and alcohol program was adding value. What it wasn't able to do was assess individual kind of grants and providers and their work, partly because the data we collect tends to be more focused on inputs rather than outputs and outcomes. With the next round of the drug and alcohol program, which starts July next year, we would like to collect more. Our plan is to collect a little bit more data. We're trying to get that perfect sweet spot between a bit more data but not too much burden for providers in collecting data. That will allow us to assess more, to do another evaluation in a number of years and have a kind of cleaner assessment of what works in what scenarios and for whom. Because we don't think it's kind of going to be this provider is perfect for everything. It might be this provider's really good if your scenario is as such. You're a young person whose primary drugs are alcohol and cannabis versus an older person who has, long-term use of opioids.
Can I just clarify, you said earlier on in that answer that you've been looking more at the inputs rather than the outputs. What did you mean by that?
I might just clarify, it's outputs more than outcomes. So we've got the...
Oh, okay, so interim measures, not.
How many clients did this provider provide care to versus amongst that group, how many then were able to achieve abstinence, how many, were able to prolong their absence for this period of time. And so those longer term outcomes, they're the sorts of things that we really want to be in a stronger position to measure in a number of years, which means we need to refine the KPIs that providers report against, and that's the piece of work that we're doing that Ms. Clancy referred to. at the start around reform of the program
Yeah.
and the consultation phase that we're going through.
And as well as abstinence, it's also quality of life.
Yes.
Yeah, has someone stabilised their life and you know, now in a much better place to participate in their family and society.
Thank you.
You mentioned earlier, correct me if I'm wrong, that marijuana use has gone up in most jurisdictions. Does that correlate in any way with the availability of medicinal cannabis?
And what for?
Well, I can talk about the supply of medicinal cannabis as our limited data, but I'm not able to talk about anything around marijuana use.
We might have to have a two-part answer, perhaps you
I think we might, yeah. So as part of the medicinal cannabis program that sees providers accessing unapproved products through the Special Access Scheme and the Authorised Prescriber Scheme, we do have some data that reflects the number of prescriptions supplied for a single person by a single prescriber. And we are seeing a dramatic increase over the last couple of years, and particularly in the category of products that have very high levels of THC, which is that portion of cannabis that gives you the high, if you like, and it's that portion that drives most of the addictive behaviour. As well as that, we're seeing...
when you say dramatic, how dramatic is it? Is it a 20% increase, 30% increase? Or?
Probably more than that. And I can take that on notice if you like for the precise numbers. But we are now seeing what we call Category 5, though technically Category 5 is a very small amount of CBD. We believe that the remainder of the product contains a THC product, so that's just one rider to it. But we are seeing now Category 5 products in a single year period outnumbering all of the other categories that are being prescribed in the Special Access Scheme. We're also seeing these being prescribed to younger population, and understanding the age criteria that we collect against is not very granular. This is 18 to 30-year-olds. And we're also seeing it being prescribed largely for chronic pain or anxiety. So it's this sort of pattern which we think is quite concerning, and it's against that sort of landscape that we have recently run our consultation on medicinal cannabis in the community, looking at a number of areas, including safety, including approvals and regulatory pathways, and other safety issues around labelling. So yes, we are seeing an increase in medicinal cannabis.
So if I could just add to that, on our side for the Office of Drug Control, we look at the supply of narcotics and we approve domestic production as well as imports. And for cannabis, imported cannabis for medicinal purposes, as an example, in 2021 there was about 7 tonnes of flour imported. For 2024 that increased to 77 tonnes.
Wow.
Now obviously the flour won't just be prescribed in flour form. We could get extracts of CBD and THC in particular.
So more than
from
10
that.
times increase.
Yeah, we've definitely seen a significant increase in the supply side of medicinal cannabis into Australia. On the domestic production side, that's also increased from 16 tonnes in 2021 all the way up to 42 tonnes in 2024. Don't have 2025 data yet. We work on a calendar year, so we're still working through that.
And I might add also that the patterns that we're seeing in the Special Access Scheme is only that part of the access pathways that have a single prescriber, single patient. There is another part of the medicinal cannabis access which deals with authorised prescriber, and that's where a prescriber is authorised to prescribe to many patients at one time, and that specific data around prescription numbers is not available to us.
Isn't it? Wow. So that's interesting. We need to explore that.
We do need to go. Do you have time to give us a few, like 10 minutes for us to come back?
Yes.
That would be great. Sorry. We'll adjourn until the division's over. Thanks. can reconvene. Sorry about that brief interruption. So we're just talking about the huge increase, absolutely huge increase in prescription and imports. Are we concerned about that on different levels, or was this predicted with the availability of medicinal cannabis?
I'm happy to talk to it.
All right, you start making that.
And I'll just preface by saying that as a paediatrician, I'm hearing about people prescribing medicinal cannabis for adolescents and even younger kids with anxiety and so-called ADHD.
And I guess in relation to that, your most recent comment, as part of the work that the TGA does in engaging its stakeholders, we have a working group called the Medicinal Cannabis Expert Working Group, which followed on from the Statutory Advisory Council that was initially established in 2017. And through that expert working group, exactly what you're talking about, the concerning numbers of prescriptions to paediatric patients, the risks of cannabis to the young brain, it was decided and implemented an additional requirement for medicinal cannabis prescribers to have a letter of support from a psychiatrist or a paediatrician before access was approved for paediatric patients. So that's been one of the steps that we've taken. I think the difficulty here that the TGA faces, or the challenge, is that these are unapproved products. And so our legislative levers, if you like, in being able to regulate unapproved products are limited to other areas such as advertising and certain quality standards that we can implement around that. So I think really where our major levers are is if there is a serious safety concern and a safety signal that allow us to then look at the type and variety and dose and method of application that is being provided in the community. And that's something that absolutely we've focused on with our recent consultation. And the sorts of things that we're hearing are indeed the concerns around safety signals, the fact that there are products being provided in gummy form that can obviously cause problems with accidental ingestion and overdose. You go.
Just to go back to your earlier point and to add to Professor Langham's comments, we didn't anticipate in 2016 when the Narcotic Drugs Act was amended to allow for medicinal cannabis, the growth would be this significant. We had anticipated that industry and sponsors would come to the TGA to register these products, in which case then they will have been through the TGA's process of looking at the safety efficacy of that and of those products. Unfortunately, that hasn't happened, and an industry has grown through the unapproved space, as Professor Langham has said. So the TGA has put out a consultation paper to look at this issue, to look at the fact that the current pathways for special access scheme and authorised prescriber are not working for medicinal cannabis. They're using a pathway that was not intended to be used as it is. And so on the whole, feedback from industry is that they agree that this is not the appropriate pathway. So now we need to go through the process of understanding what we need to do, both from a Commonwealth perspective but also from industry, in order to change how medicinal cannabis can be accessed in the market. And so that work is just very early stages at the moment. The consultation only just finished. I don't have the numbers in front of me, but there were, I think 600 or 700 submissions to that, which the team are now going through, and we will look at what we can do in the short, medium and long term to address what's happening at the moment.
Because, correct me if I'm wrong, it's available via telehealth now, isn't it? There's a number of differing aspects to the industry, both from the supply of the medicine and the fact that it is an unapproved good. In fact, a number of patients were not aware that the TGA had not assessed
these medicines when they were prescribed to them. So that's something we need to look at. Telehealth is outside of the work that's currently being done. TGA doesn't regulate prescriber behaviour or clinics. So at this point in time, while it's acknowledged that there are a number of factors within the industry that need to be looked at, the consultation from the TGA side is looking at the medicine aspect of it and the therapeutic good.
Yeah. I imagine it would be difficult to regulate these products, would that, individually?
In particular, as unapproved products, yes. If they go through the process and become registered on the ARTG, then the TGA has significantly more powers to regulate the products.
Good. Thanks. I'm conscious of time, but did any of my colleagues have any questions? No. Okay, well, look, thank you so much once again. We are very grateful for you giving us your time. And I know this is not the first time you've appeared before us, so I would like to thank you so much for coming back. We are having a few more public consultations, including going to Perth in early or to mid-April. We hope to finish our report by May, and obviously you'll get a copy of our report. But what you've told us is very valuable, and we really do appreciate it. If there have been a couple of things you've been asked on notice, if you could deliver that to that details to the Secretariat within the next couple of weeks, that would be great. And if you have any concerns about the transcripts of today, please contact the Secretariat and we can make corrections.
Can I ask one other question? On notice, no, just to you.
Sure.
Could we have the outcomes of that study, of that inquiry? You said that there was an inquiry into medical cannabis. Will we be able to have those results when they become available?
So it's not an inquiry, it's a consultation.
Oh, right.
So we've asked a number of questions around medicinal cannabis and the supply of medicinal cannabis and the products themselves. So that's public. So those documents are public. We can provide them to you. We will need to look at the submissions. I don't know if the submissions will be published. I think if individuals don't want them published, then we've got to be conscious of that. But we'll have probably easier just to send you the link. We can send through the link of the page on the TGA website for that.
That would be great, yeah. So thank you, and thanks once again for coming.
Thank you for your questions. We will aim to get things back to you within a couple of weeks. I think one thing we said we'd look for from our state and territory colleagues. That'll probably take a little longer, but we'll get it to you as soon as we can.
Thank you very much.
Thank you.
Thank you.
It seems very odd, doesn't it? We have an unapproved food, and we have these telehealth providers just like meditation going when it comes to those highly addictive products.
Correct.
Yeah, good. How are you doing? Because I put my hand up. There's a delegation to go to Timor-Leste, and they needed somebody from the crossbench. So, yeah. You are good? Okay. Oh, well done. Yes, so I might be going to Timor-Leste. Yeah, even though I'll come to WA. Yeah.
That's interesting. Right? Yeah. Yep. We're going to call the other witnesses. We're calling the other witnesses now. You'll be back. I will be back. Sure. I'd like to now call witnesses from the National Indigenous Australians Agency to give evidence at this public hearing today. So thank you very much for coming along. I'll get my members to identify themselves first.
I'm Sophie Scomps, member for Mackellar on the Northern Beaches of Sydney.
Mike Freelander, I'm the member for Macarthur in South West Sydney.
And Gordon Reid, member for Robertson on the New South Wales Central Coast.
And Sam Birrell, the member for Nichols in Victoria, has just had to step out, but he will be coming back. If you could identify yourselves, that would be great. And if any of you would like to make a short opening statement, we would appreciate it. This hearing is being broadcast, and you'll be given an opportunity to view the transcript at the end of the meeting, or sometime in the next few days. And any corrections you want to be made to the transcript will be fine. Now, would you like to identify yourselves and make a short opening statement?
Thank you very much, and good morning, everybody. My name's Deborah Fulton. I'm the Acting Deputy CEO for Policy and Programs at the National Indigenous Australians Agency. And I'll go to my colleague here and then to Ali online.
Morning, everyone. Catherine Orchard, Branch Manager of the Health and Wellbeing Branch.
And
hello, I'm Ali Jenkins, Group Manager for Social Policy.
Good.
Thank you. Ali's dialing in from Hobart, where she's based.
Good.
I don't have a particular opening statement other than to thank you for inviting us here and acknowledge, as you did share earlier in the morning, that we're meeting here on First Nations land. I'd like to pay respects to Elders past and present. And I think we're happy to go straight to questions, or if there's particular themes that that you would like to draw out from the submission that we gave some time ago.
Yep. Well, I might just start briefly. Could you let us know who is the National Indigenous Australians Agency and who funds you and which areas you cover around Australia?
Yes, so we were established as an executive agency in July 2019. So we are part of the Prime Minister and Cabinet portfolio, Commonwealth Executive Agency. We have executive orders that go to a range of issues like coordinating for the Commonwealth on closing the gap, delivering a range of programs to benefit First Nations people, including around remote employment. We also have orders around coordinating for the Commonwealth on reconciliation activities and a number of others. So we've existed in various forms. Before we were created as an executive agency, we were a group within Prime Minister and Cabinet, and probably the most significant development before that was a machinery of government change that brought a range of Indigenous-specific programs from around Commonwealth entities into an Indigenous affairs portfolio, if you like. So we have a range of programs. They broadly come under sort of jobs, land and economy, so remote employment, business supports, Indigenous ranges, a range of programs that go to health and wellbeing, family safety, justice, culture and capability, and remote Australia services. And the biggest programs that we're involved in delivering relate to remote employment, Indigenous ranges, remote housing, and we do have a range of smaller programs that go to health and wellbeing, early years education, which where there are Commonwealth entities with the sort of primary responsibility for that, as we have with Department of Health on the topic of this inquiry. But we do have a range of sort of smaller grant programs that we run that are complementary to mainstream efforts.
Good. And so your funding's pretty much all federal?
Yeah.
yeah, good. Okay, does anyone have any questions? Yeah, Sophie.
Hi, how are you? I was interested in about the steps being taken to train and better support First Nations people in the workforce for alcohol and other drugs.
Yes, so I'll say a couple of things and then I might pass to you. It is a challenge for attracting and retaining sufficient workforce in our program. So we have a number of grants that come to more or less 70-odd million a year that go to alcohol and other drug services, and that's probably across maybe 80 or so grants. So we provide flexibility within those grants for professional development and for those organisations to look at what they can do to support their workforce, but we don't have a sort of a significant specific program that goes to workforce capability. It is acknowledged as a barrier both for attracting and retaining, and kind of ensuring sufficient development for the workforce. Catherine, did you want to add anything?
So within our funding, we, as Deborah said, we've got approximately 80 activities across 170 locations across the country. Out of those activities, we employ approximately 600 staff, and of those 600, 400 are in direct service to clients. The grant agreements are a flexible agreement where organisations can use it, if funding allows, to use it for professional development and training of their workforce. But as Deborah said, there is a barrier workforce, and it is the consistent messaging we are receiving from our providers.
What in particular was the barrier? Just finding people who are... Do you feel there needs to be a specific program that is addressing alcohol and other drugs training programs, or is it?
I'm not certain that it's a lack of access to ability for training or access to courses. I think it would come into a category of as a number of professions around the level of recognition and payment for people. In some cases, it's a difficult area to work in. So for sustaining people in long-term careers, we would have in some of the programs we operate in the additional barrier of operating in remote Australia, where it's difficult to find a workforce in any case. So I'm not sure it's access to courses that address the skills. It's sort of broader workforce challenges.
Can I just add to that? Is there, how are we going with training just health workers, First Nations health workers?
So that's a measure that the Department of Health lead on, and I don't have the latest, but I think it's going quite well. I think they've had a high level of intake. I don't have the numbers on the number of people who've graduated through it, but that's a very positive initiative that the Coalition of Peaks have been closely involved in, and I believe it's going successfully. Thank you.
Good. Thank you for coming today. My question is also surrounding workforce. Does the NIAA have any evidence or would like to make a statement regarding how Aboriginal-led services actually improve outcomes in the alcohol and other drug space?
Yeah, so it's definitely a key area of priority for us is ensuring that we're supporting a community-controlled sector for the Commonwealth and all jurisdictional governments that signed on to the National Agreement on Closing the Gap. There's a fundamental recognition in there that services across a lot of areas are improved when they're delivered through a community-controlled organisation and workforce. And that's not specifically in this area, but is quite broad and is something that the Commonwealth has kind of committed to across its First Nation-specific programs. So progressively moving towards supporting more community-controlled works organisations and working in partnership in the design and delivery of those. So there is a lot of qualitative evidence, including through the Productivity Commission's reviews on the Closing the Gap, and more recently a Aboriginal and Torres Strait Islander-led independent review of Closing the Gap. So it's not looking specifically at alcohol and other drugs, but it's looking more broadly around the benefits of the community-controlled organisations providing services. There's much more probably case study based data that kind of exists a little bit sporadically around having kind of data sets to complement the complementary side. I don't know of any specifically in alcohol and other drugs, but I know in some early childhood related areas, for example, they've had a chance to look more long term at life outcomes and seeing improvements there.
And sort of a workforce related question. Does the NIAA run any programs or any sort of upskilling programs for clinicians or workers that might be already working in the space? So say an RN who's already working in a detox unit that wants to upskill in Aboriginal health in this area. Does the NIAA run any programs in that regard, or would that be more state-based training programs through?
Yes,
districts?
that would be more state-based and potentially through Department of Health. So within some of our grants, as Ms Orchard mentioned earlier, there's some flexibility for providing capacity building and support, which in some cases may go to accessing higher level skills, but it's not a program that we run. It's more flexibility within existing grants and not a primary function of the agency.
And from what you were saying before, there's obviously issues with workforce recruitment and retention in that area. Is there an area that is at sort of that critical mass point? So is it sort of your doctors and nurses? Is it your counsellors? Is there an area of that workforce that you would identify as having the most sort of critical shortages for Aboriginal and Torres Strait Islander populations?
I would say it's all. All
of them?
Yeah, there's a number of professions that fly in, fly out, and that's great, but also brings its challenges to be able to work with community in a culturally safe, trauma-informed approach. There is nurses, there's counsellors, there's all those spectrum, but I wouldn't say there's one profession over the other that is more needed. I'd say it's across the whole spectrum.
Cool. Thank you very much. Thanks, Chair.
Thank you. Apologies, I had to step out then. I'm Sam Birrell, member for Nichols, which is in Northern Victoria. And I would like to ask whether there is any trends on drug and alcohol issues in First Nations communities, depending on where in Australia they are.
We don't have it based on location. We use the Australian Institute of Health and Welfare data, which doesn't drill down to that level of detail. Tobacco smoking is declining.
Sorry, I might just, if that's the case, then I suppose I asked the question where in Australia, but maybe we could talk, would it be better to talk about metropolitan, regional, rural, remote? Would that be?
Again, we're relying on the Australian Institute of Health and Welfare data, and it's very similar to what our colleagues from Department of Health presented just before.
Yeah.
First Nations trends are tracking the same. It's just the higher prevalence in First Nations cohorts as well. So, for example, tobacco smoking is declining for First Nations people, but it is higher compared to non-First Nations people. But I don't have the level of data versus metro, regional, remote.
Okay. Would it be possible or useful to somehow have that data?
All data would be welcome.
Yeah, I opened up that question.
Yeah.
Yeah, I agree. Okay, it's interesting just to see in the focus of where to target the efforts and whether efforts need targeted in certain areas are different from other areas. Okay.
I think it is, along with workforce, that is identified as another barrier. Like, it would be great to have access to more data and more that meets Indigenous data sovereignty principles as well. It's another gap. Yeah.
Okay. Thank you.
Good. Alice?
Thank you so much for appearing before our committee today. Your submission specifically calls out AOD use in pregnancy and sort of calling for increased support for pregnant and parenting First Nations women and their children, and sort of details sort of some under-resourcing and confusion around the role of agencies and supports in this space. Could you elaborate on what supports you'd like to see and how we can better support this cohort of women?
Yeah, it is an emerging trend. It's more in the early intervention stages that we would like to see additional supports and funding available, where our Aboriginal controlled health services can support First Nations women and children and parents in the harms of alcohol use in the lead up to being pregnant and during pregnancy as well. We did a national consultation, which we've mentioned in our submission in 22-23, and that came through consistently through those consultations. There's a couple of providers across the country who are doing some key fetal alcohol syndrome activities in their community as well, which is quite interesting to see as that progresses along. But we believe that early intervention stage is where we can have big wins.
Thank you.
Oh, I was very interested in the fetal alcohol work as well. I've asked a couple of questions, so I wasn't going to ask any more. I'll let you go, Chair.
I've got some real concerns about child maternal health in the Indigenous space, particularly around fetal alcohol syndrome, particularly around birth weight, particularly around very disjointed services. Would you like to make a comment on any of those things? Particularly the disjointed services. I mean, do you interact well with health? Do you interact well with Indigenous affairs? Why is this in Prime Minister and Cabinet?
So I think there is always a range of services depending on the kind of primary responsibility between jurisdictions, the Commonwealth, and then the nature of the programs we do. Our funding in this area is complementary to health. We do work closely with health and with other agencies on other sectoral programs, and we are looking to really see what we're hearing from communities around what they need and want. It is a common comment from stakeholders around the difficulty in navigating the whole system. You know, should it be whether it's the jurisdiction or a different part of the Commonwealth, and us all having slightly different arrangements and grants and the like. So it is acknowledged as an area that we do need to keep working on. It feeds into the requests for us to support more Aboriginal community-controlled organisations and work through peak organisations and those. So I think it is an area that we're continuing to work through, including through the kind of Closing the Gap framework and work with the Coalition of the Peaks. I would say it's a live kind of conversation for us.
Yeah, I mean, for example, in 2024, this committee went to Northern Australia, and in the Northern Territory in particular, around diabetes, their complaints were not enough Aboriginal health workers embedded in communities, very poor follow-up of babies at high risk of fetal alcohol syndrome, very poor supports in that first 1,000 days, which is critical, we know, for growth and development, and then lack of support for kids with disabilities due to fetal alcohol syndrome, particularly in rural and remote areas. Are there any plans to increase our support for that early days in Indigenous communities?
So there's no plans at the present around increases in funding through NIAA around this area. I think we do look to what we can do to complement others better, reduce the sort of administrative complexity, and there would be larger programs run through jurisdictions and through Department of Health, and we're sort of looking to try to have our programs as sort of complementary and non-duplicative as we can make them.
Good. Okay. And again, and this is something that has come up in other health issues as well, it's very difficult to provide support services in rural and remote areas for treatment options for alcohol and other drug addictions. And also, and this came up a little bit even in the diabetes inquiry, there seems to be increased availability of some drugs in Indigenous communities, such as amphetamines. Have you looked at that at all?
We wouldn't have data to support that. The Department of Health may, but we wouldn't have.
Okay. Good. All right. Thank you. Any other questions? No?
No, I'd like, and I'm not putting this onto you, I'd like us to know, us as Australia to know, of the 3.8% of Australia's population, which is First Nations people, Indigenous people, Aboriginal people, 40 to 45% are in major cities, 30 to 35% are in regional areas, 15 to 20% are in remote areas. It would be very interesting to know whether the prevalence of drug and alcohol issues changes with some data. So it's something I think if we could all take on board.
It would certainly be useful.
Yeah, we would find it very
and there
useful.
would be jurisdictional data in some cases, I
Yeah.
think, that the Commonwealth doesn't have access to, but yes, we would certainly agree.
Yeah.
Thank you.
Yeah.
Good. Well, thank you very much for coming today. Really appreciate your time. And if you've been asked to take anything on notice, if you could deliver that to the Secretariat within the next couple of weeks, it would be appreciated. And you'll have the opportunity to view the transcript of today and make any corrections you would like. Thanks very much for coming. And there may be some subsequent questions we may want to ask you if you're available for that. That would be great. So thanks once again.
Thank you very much.
Thank you.
Thanks for the opportunity.
And I will now call this public hearing closed. And thank you. Members.